Okay, thank you very much. This work is about genetics of common variable immunodeficiency, which is quite a challenging field. CVID is the most symptomatic primary immunodeficiency, and patients have mainly hypogammaglobulinemia and poor response to vaccines. Some of them have other complications like autoimmunity, lymphoproliferation, or immune dysregulation, and the therapy is based in immunoglobulin substitution. So the genetic basis is complex. You can see here all the genes that have been associated to CVID in the last 20 years. Not all the genes account for the same proportion of patients. You can see here the top 10 monogenic defects, at least in European cohorts, led by TNF receptor superfamily member 13B, a long name for TACI, and then FKB1 and FKB2, CTLA4, LRBA, etc. Other genes account for few patients. For example, SAGE3 was identified less than 2 years ago, and we reported the first patient presenting with a phenotype of common variable immunodeficiency. In any case, all these genes account only for a minor percentage of patients. Usually, monogenic defects are identified in 15, 20, 25% at best of patients. So what happens with the other patients? Other non-monogenic models have been proposed, including the digenic model or oligogenic model. This is a nice paper of Rohan and Miratunga showing a patient with TACI and TCF3 variants, which would be a digenic example, for example. Then the epigenetics have also been proposed. Here in Catalonia, we have Esteban Ballestar that is working in this field for many years, and he published a very popular paper about two discordant twins for CVID. Then the polygenic model is probably playing a role, but this is difficult to demonstrate because it's based in multiple genetic variants, each of one giving only few risk for the disease. And even somatic variants have been proposed, but still not demonstrated. So in this work, we are interested in X-chromosome inactivation process. As you know, it is a dosage compensation mechanism that occur in females. It occurs at the first stage of embryonic development, probably around the 8 cells stage. And in this stage, each individual cell independently and randomly inactivates one copy of the X chromosome. So this makes that most of females are mosaics in which some cells inactivated the paternal X chromosome and some cells inactivated the maternal one. Since this is a random process, sometimes most of the cells inactivate the same chromosome, the same X chromosome, and this leads to the concept of a Skewed X-Chromosome Inactivation. This is not a very rare phenomenon. More or less 5 to 10% of women have a Skewed X-Chromosome Inactivation. This is not a problem at all, except if you have a heterozygous pathogenic mutation and you inactivate the wild-type chromosome. For example, that's the case of this manuscript that we recently published about chronic granulomatous disease. There is a poster in this Congress presented by Laura Vall, if you are interested. And how this X-chromosome inactivation status is measured. There was a classic model called the HUVH assay. I will not go into details for the matter of time, but it's based in the different sensitive effect of a restriction enzyme between methylated and non-methylated chromosomes, because the X chromosome inactivation is based in methylating the inactive chromosome. So in this study, we addressed this question: do Skewed X-chromosome inactivation play a role in CVID? To do that, we had a cohort in our hospital of 131 CVID patients. All these patients have been analyzed with the NGS panel of more than 300 genes. Then we take only the females, 61, and in these females, we selected those that carry rare variants in CVID-related genes located in chromosome X. So finally, we end with these 4 female patients, 2 of them carrying variants in the BTK, that is classically causing the Bruton agammaglobulinemia, 1 patient with a variant in CD40 ligand causing hyper-IgM syndrome, and 1 with variants in EKBKG that codified by NEMO that causes also immunodeficiency with or without ectodermal dysplasia. And then we analyze the X-chromosome activation in all these patients. So the results are the following. Here you can see patient 1 and patient 2 that had two missense variants, two rare missense variants in BTK. These missense variants were classified as variants of uncertain significance. And then we wanted to assess the X chromosome inactivation status using not only the HUVH method, but another more precise method, which is analyzing the mRNA expression of the target gene. So the idea is, you can see here that in the genomic DNA, both patients have this double peak corresponding to the wild type and mutated allele at the same proportion in genomic DNA. And then we analyze the cDNA, and the idea is that if you have a random X chromosome inactivation, in the cDNA, you will see the same contribution of the two alleles. That's the case of patient 2. You can see here the equal contribution of both alleles. So this patient has a random X chromosome inactivation. So we consider that this BTK variant do not play a direct role in the CVID phenotype of this patient. But in patient 1, you can see here an imbalance between the presence of both alleles in the cDNA, and interestingly, the mutated one, which is the blue one, the cytosine, is the most predominantly expressed. So this patient had a Skewed X-Chromosome Inactivation where the mutated allele was predominantly expressed. So it represents a genotype intermediate between heterozygous and homozygous state. This proportion was precisely quantified by NGS, and the mutated allele was expressed at 80% and the wild type 20%. This would be the ratio of X chromosome activation that we confirm with the HUVH method. Patient 3 was a special case because when she attended our hospital, she just had a son diagnosed of hyper-IgM syndrome due to a pathogenic mutation in CD40 ligand. She was carrier of this mutation. Usually, female carriers are asymptomatic, but because of his CVID phenotype, we immediately thought that she could have this Skewed X-Chromosome activation. Still, we did all the gene panel to exclude other genes involved in CVID, and indeed, the only relevant variant was this pathogenic variant in CD40 ligand. So we then analyzed the cDNA. This variant is a splice variant that causes two different aberrant transcripts, one transcript lacking exon 2 and one transcript with a partial intron 2 retention. And the cDNA, this is antisense strand. So after exon 3, you can see three transcripts, different transcripts. One, the wild type is going from exon 3 to exon 2, and the two mutated ones correspond to the ones lacking exon 2 and the one with partial intron 2 retention. So to see the contribution of the wild type allele, we must find a position in which the three transcripts have a different nucleotide. This is not the case of first position, nor the 2 or 3, but the fourth position, you can see that there are three different nucleotides, and the cytosine of the wild type allele is minor represented in the cDNA, and the same happens with all the positions. So this indicates that wild type allele is residually expressed. HUVH method confirmed this Skewed X-Chromosome activation. So in this case, the CVID phenotype is due to this Skewed X-Chromosome activation in which the predominantly expressed allele is the mutated one. And finally, patient 4 had this rare variant in NEMO, but in the gene panel, we also identified a heterozygous, probably pathogenic mutation in TACI. This was a splice site mutation. TACI is not in the chromosome X, but the mutation was in the panel, and it was an undescribed mutation, so we first characterized the splicing defect in TACI. I will not go into details, but the splicing mutation led to exon 2 skipping, so we consider that that patient carried a heterozygous pathogenic variant in TACI. These monoallelic pathogenic variants in TACI are considered as risk factors for CVID and could not be considered as causal factors by itself. So then we analyzed this missense variant in NEMO that has been previously published as a hypomorphic variant, so a variant that slightly impairs the function of NEMO. Again, in the genomic DNA, you can see the double peak corresponding to both alleles at a 50-50 ratio. And in the cDNA, you can see that there is an imbalance. And again, the mutated allele is, this is the adenine, is predominantly expressed. HUVH assay also confirmed this ratio of about 83-70%. So the patient had this Skewed X-chromosome activation. This case is interesting because this patient had a heterozygous pathogenic variant in TACI, that should be a risk factor, and then this heterozygous hypomorphic variant in NEMO plus this phenomena of skewed X-chromosome inactivation. This could be an example of a digenic contribution in CVID. So in summary, we identified 4 female patients with rare variants in CVID-related genes in chromosome X. 3 of these patients had a skewed X-chromosome inactivation, but interestingly, in all these three patients, the predominantly expressed allele was the mutated one. So the take-home message is that we can consider this phenomena as another piece in this complex puzzle of CVID genetics. So this work is mainly done by Marina Garcia and also Laura Valle and the rest of the team of Translational Immunology Group and Infection and Immunity Pediatric Patients Group in Vall d'Hebron. Thank you very much.
Okay. So is there any question for this presentation? There is a question here.
Thank you. That was very interesting and a very nice testing of the hypothesis. I have a few critical questions, but not to take away from the interesting work. The BTK, you did the cDNA. What was the cell source of the cDNA?
Sorry?
The cDNA analysis, what was the cell source?
Yeah, the cDNA was from total blood.
Because if you would suspect a female or at least somebody having a BTK defect, you would expect no B cells, because without BTK you don't have B cells.
Yeah, so the idea is that first, these 2 variants were variants of uncertain significance,
Sure.
so we cannot consider as pathogenic a priori. Sure. But the idea is that if you have this skewed X-chromosome inactivation phenomena, you will have a phenotype not like the Bruton agammaglobulinemia, because you still have some wild-type allele expressed. So the idea is you can have an intermediate state, and that's we analyze using the total blood.
Sure, I understand, but if it's 50-50 and she has B cells, then of course there's no causative BTK. So I'm wondering, did she have B cells?
Yeah, it's possible. So in the case of BTK, patient 1 had this skewed X-chromosome activation. We cannot prove that this is causing the CVID phenotype, but we cannot exclude that this not play a role in the phenotype. So that's our idea.
I understand, but did she have B cells?
Yeah, she has B cells.
Because then by definition, these would all be...
Yeah, but for example, I will not go into details, but the variant that had the patient 1 has previously described in a paper with Bruton patient with milder phenotype with B cells. So it is not a black or white phenomena in this case, but I agree with you that it's not a fully pathogenic variant, because otherwise the patient would not have B cells.
Yeah. And for the CD40 ligand, did you confirm that by protein expression? So then you would, if that's indeed skewed, then most of the T cells will not upregulate CD40 ligand upon stimulation?
Yeah, we did not confirm that.
Okay. It'd be interesting to see.
Yeah.
Because I've always been taught you should be careful interpreting the peak heights on sequencing patterns, because they're not equal.
Yeah, I agree. However, we confirmed these peaks in the mRNA, we confirmed also with NGS that I will not show. I did not show because of time, and also with the HUVH assay. So the X-chromosome, the skewed X-chromosome activation is clear, but what we did not do is the protein expression.
Yeah. No, that'd be good to add. I think that would be convincing.
Yeah, for sure.
Thank you.
Thanks.
Thank you. Let's move to the next talk. Oh, there is another question. Sorry.
The other day we were discussing with Charlotte after the immunology club about what is a CVID or not. I would like to know your opinion about all these patients, the ones that were in this annual review paper, but also yours. Are CVID or because there is a mutation that has been established, they move away from the definition?
Yeah, this is a good question. And in our cohort, all the patients follow the ICON criteria for CVID. But it is true that I showed you a nice figure from a recent review of the group of Vall and VHIR with a lot of genes that are not CVID typical genes, but that have been reported in some CVID-like patients. So I don't know if in all the cohorts I have doubts, that in all the cohorts, all the patients follow the strict rules of CVID to be included in that cohort. Sometimes these cohorts include hypoglobulinemic patients that are not strictly CVID patients, but this is a matter of a long discussion.
Thank you very much.
Thank you.
Okay, thanks.